recording. Okay, it should be going. Okay, hello everyone and welcome to another ITSS Verona podcast by the Human Security team. I'm Ludovica and I'm here with my colleague Arslan. Today we have the honor to host two special guests, Professor Simon Rushton and Dr. Adam Ferhani from the University of Sheffield. And Simon is also Associate Fellow of the Global Health Program at the Royal Institute of International Affairs and Senior Fellow of the Center for Global Health, Security and Diplomacy. So they both focus their academic research and expertise on the areas of health security, global health politics, but today they are here to help us unpack the implications of the bordering practices implemented during the COVID-19 pandemic. So welcome, Simon and Adam. Thank you very much for being here with us today.
Thank you. It's nice to be here.
Okay, so let's get started. I will hand over the mic to my colleague Arslan to introduce us maybe with the first question.
Thank you, Ludovica, and thank you, Dr. Adam and Dr. Simon for joining us today. It's a privilege to have you both here. Without taking due time, valuable time of yours, so I would start with the first question and would like to continue it as a discussion and see what your expertise has to say on this question. So my first question would be, during the pandemic, most countries have used the discourses around national security to reinforce or create exclusionary bordering practices. However, we have also seen the emergence of travel bubbles and green lanes for those who were considered eligible. Can you give us some insights into the bordering practices implemented by the different countries during the pandemic, and to what extent are they reinforcing old exclusionary dynamics, and how have they evolved throughout the different phases of the pandemic?
Great, thank you, Arslan. So I'll start and then I'll hand over to Adam. First of all, just to agree with the starting point of your question, I mean, it's very clear that particularly in the earlier stages of the pandemic, most countries, maybe not all countries, but the vast majority of countries very much approached it through a national security lens, in which the imposition of controls at their borders of who was coming in and who was coming out was really a major part of the effort to control COVID-19. And I think in many ways that was a logical continuation of what had been happening over the previous couple of decades, where countries have increasingly come to see disease outbreaks not just as health problems, but as national security problems and as problems that they needed to protect themselves against. And I think that had been very clear, particularly in rich Western industrialized countries. I think there'd really been a kind of drift of policy towards approaching disease problems in those terms much more. And we saw that very early and very quickly in the COVID-19 pandemic, with, as I've already said, most countries seeing that control of borders as being a really key part of COVID control. Even, and this is, I suppose, one of the ironies, even when they already had major domestic outbreaks, they still understood stopping people coming in or limiting who was coming in as being an important part of that public health response. But I think one of the things that Adam and I tried to talk about in a paper we published actually relatively close to the beginning of the pandemic was there were other exclusionary practices happening too, and borders were manifesting in different ways early in the pandemic, not just controlling people coming in and out across national borders through ports and airports, but also in a number of other ways. And maybe at that point, I can hand over to Adam to talk about some of the other kinds of bordering we saw.
Yeah, sure. Can you all hear me? Is that working? Right, brilliant. Yeah, I think one of the, I think certainly what we write about in that article, and we've talked about an awful lot since, the IHR generally understand borders as, you know, lines in the sand, as very much in sort of the traditional sort of territorial limits, which isn't necessarily wrong, because obviously that comes into, you know, health security generally, and certainly with COVID. But then we saw the Wuhan evacuations, we saw exports and imports being restricted, and then obviously more recently, given vaccine rollout, we've seen restrictions on, you know, who can and can't travel being predicated on whether or not you've been vaccinated. So, you know, the bordering and exclusions taking place in various ways beyond, you know, points of entry. I don't know if you want to add anything to that, Simon, or...
No, I would just say that, you know, I think, again, all of that reflects that that kind of national security approach to addressing disease outbreaks. What we saw, particularly in the early stages, just to pick up on the trade restrictions that Adam mentioned, was very often countries banning exports of particular things that were thought to be important for dealing with the pandemic, whether that be protective equipment, ventilators, all of those kinds of things. So in contrast with this narrative we've had about global health security and the need for global cooperation, what we saw very quickly when the emergency hit was a turning inwards, was a kind of prioritization of domestic interests first, and the border in various ways being a really key part in which that was enforced, I think.
I think one thing I'd certainly add to that is, I think, given this is sort of under the banner of global health security, which is a sort of doctrine, an idea, you know, promotes, you know, the idea that, you know, the health security on a global scale is, you know, dependent on the health security of individual states. I think if it stands to reason that borders will always come into it, because, you know, this is the paradox, you know, we talk about global health security, but if the idea is that it's promoting more health security, then there will inadvertently be more bordering, if that makes sense. I'm not sure if I've explained that very well. Simon's nodding, so I'll take that as a yes. Which is something that's not really discussed. You know, global health security is, you know, this sort of brilliant thing. You know, we want to be safe from outbreaks of diseases, but if that's based on the health security of individual nations or states, there's a conflict there.
Yeah, so it appears
Absolutely
to be like a conflict, a tension between like an attempt to a global health governance and the national practices, which is very well exemplified by what you just explained. And so you were talking about, Adam, about a new conceptualization of borders and how it is clear that the pandemic reinforced our idea of borders, but actually created new ways of understanding borders and exclusionary bordering practices. So how can, like, a new concept, what would you say, like, can you comment on this tension, and what would you say is a new concept? How can this new conceptualization of borders help us to address this tension between, like, a global governance of health security and the national practice, a national policy?
I mean, I think first things, I mean, I think what I would say is with the IHR, with the sort of the revised 2005 iteration, you know, there was this sort of supposed shift away from bordering, you know, to, you know, there was this movement towards, you know, containment at source. One thing I would say that's not entirely true, because there is, for my PhD research, there is routine stuff going on at borders constantly, which is to meet requirements of the IHR. So in that sense, I'm not entirely sure there was a shift away from borders that in the way that they claimed. But more broadly, we're not discussing whether or not the IHR need to be revised. I think that's probably the topic of something completely different. But I think there needs to be an acknowledgement in the IHR that, if we are talking about borders, we can't just be talking about them in the sort of traditional sense. And there needs to be that acknowledgement, for exclusion to be taking place. Within critical border studies, there's been an awful lot written about, offshoring of borders. In reality, that's kind of what we've seen. The links between health and the border can go back to, the Black Death. It's not new. But this sort of weird offshoring and the sort of the different sort of strategies that were employed, I think particularly early on in 2020, that needs to be acknowledged by the WHO. Simon, I don't know if you want to add.
Yeah, I think there's two things that I would want to add in response to your question, Ludovica. The first is to acknowledge the tension. And it's clearly there. The first thing that in almost all discussions of pandemics pre-COVID, almost everything that was written, the first thing it would say would be, we live in a globalized world. Pathogens don't recognize human borders. A pathogen that emerges in any place can be in just a few hours at any other point in the world. That narrative is a narrative that borders are not very relevant anymore for disease control. And that was very much, I think, the narrative that underpinned the revision of the international health regulations in 2005 that Adam was just talking about. Yet, when the emergency strikes, borders are clearly relevant, right? Borders are not only relevant, they're the very first thing that states go to try to control the spread of disease. So those two narratives are clearly in tension, right? There's this narrative of globalization has rendered these borders meaningless, but that yet they're still one of the only tools that governments have when they want to try to stop disease coming in, almost however futile they know that will be. So I think that's a clear tension that's there. And I think there's another tension that's there, and this is something that I think hasn't been discussed enough, and that Adam and I are working on at the moment, is the tension between bordering practices and human rights and civil liberties of various kinds. And I think we see this in all kinds of different ways, and none of this is new during COVID-19. Indeed, there's a real long history of people in public health being extremely worried about what happens at borders when health is used as a justification or as a reason for excluding particular people. And that is, I suppose, the flip side of seeing health as a national security problem, is when you say that, actually what you're saying is you see people with a particular disease as a national security threat. And once we interpret people in that way, then very often historically we've done things to them that haven't been very nice. So, for example, there was a big campaign over years, and it's to some extent still going on, against travel restrictions on people with HIV. And many countries around the world refuse to let people living with HIV enter their countries. And the public health community fought really hard against those kinds of restrictions on human rights grounds by arguing it's discriminatory to not allow people to enter your territory with a particular disease. Now, we might want to say, of course, that the context of a kind of rapidly moving fast-paced pandemic like COVID-19 is different, and maybe we can accept those restrictions in this particular case and not in others. But nevertheless, it's still striking to me, I think, how quickly and how readily most people in the public health community embraced borders as being a strategy for trying to keep disease out, even though, to bring what I've just said all together, firstly, it was widely known this wouldn't work. And indeed, border controls were being put in place even when the disease was already in countries. And secondly, this long history of concern about the human rights implications of bordering practices. So there's a whole range of different tensions here, and countries end up with policy responses that are quite hard to square with everything that we think we've learned about human rights and public health in the decades before the pandemic.
What I want to add to that, I don't know if still on. I think because so much sort of weight was given to what public health experts thought about the pandemic, there's, we need to look at the science, we need to look at the data, we've had that for the past 2 years because so much trust was put in public health professionals. It kind of rendered all of these decisions legitimate. It just wasn't questioned. There was no sort of sense of there being an alternative. So it kind of normalized these sort of pretty bleak, practices that were going on.
Mm. And the last thing I'd want to just say about this is about, Adam mentioned this already, I suppose the unequal situation we find ourselves in now in terms of vaccination passports as being what enables certain people to travel, but makes it impossible for other people to travel. And it's very interesting how quickly that's become, I suppose, just the de facto situation. Is those people lucky enough to live in countries that have had early and rapid rollout of vaccines? And I'm sitting in one of those countries, the United Kingdom, where the vast majority of our people have had 2 or even 3 vaccine doses, and as a result, we're allowed now to travel almost anywhere. But those people in countries that don't have those benefits still find themselves much more restricted. So there are clear kind of global inequalities in terms of not only implementation of border controls in the first place, but also how we've lifted those and the ways in which we've lifted them for certain groups of people and not others. Now, we could argue about whether that's right or wrong epidemiologically, but it's certainly true that there's a global inequality created as a result there.
Thank you. So thank you very much. So these really adds something to this scenario, and I might be picking up a very little piece of the puzzle that Adam mentioned before, but I'm just gonna ask it because where you were talking, I think you used the word like normalization, how it's very, I think it's very interesting how the pandemic has been used, or however, it has mainly been used to normalize certain unequal conditions that you were talking about just now, Simon. So like this pandemic exceptional situation normalizing these inequalities, and this is how it's very much connected to human rights. So I'm really looking forward to read your new paper, which this is what you will talk about, right?
That's exactly right. And I suppose what I should say, just I suppose there's a slight nuance on that, is much of this isn't new. It's always been the case, for example, that people from particular countries have had to, for example, make health declarations in order to enter certain other countries or in order to get visas and so on. So there's a longer history here, but I think it is something which has become much more widespread and much more normalized, to go back to that word, during the kind of emergency politics of the pandemic.
Thank you. And Arslan, do you have any questions?
Well, I'm afraid both our experts have this discussion was going really very interesting, but we are constrained by the time format of this podcast. So I would really love to take this discussion forward, but I'm really sorry, I'm really constrained by this time format. So maybe some other time we would continue this further. So
Yeah, thank you, Arslan.
Thank you.
Definitely. We will love to have you both again. And yes, we can wrap up this great podcast. And thank you very much for being with us today. And we really do look forward to having you here again, maybe talking about your new research and also other topics. And so I hope you have a great day. Thank you, everyone, for listening to the podcast, and have a great day.
Great, thank you.
Thank you.